Jahangeer Basha from the Asian Institute of Gastroenterology in Hyderabad, India, will talk to us about pancreatic exocrine insufficiency and acute pancreatitis. Test and treat, or treat all.
Thank you, sir. I thank Dr. Sudipto, Dr. Pramod Garg sir, and the entire team of Pancreas 2025 and CMC Vellore for the kind invitation and giving the opportunity. And thank you, chairpersons. And in fact, it's my privilege to talk Dr. Vikesh Singh on the chair, because the talk I'm going to discuss, he has done tremendous work, and many of his papers I'm going to quote. Thank you. So I'll be discussing pancreatic exocrine insufficiency in acute pancreatitis, but the talks given me to is to address whether we need to test and treat or we should treat all patients. So there is extensive literature about pancreatic exocrine insufficiency and also guidelines in chronic pancreatitis. But when it comes to acute pancreatitis, there is a scarcity of the literature and guidelines are also not there. So we need to understand the magnitude of this clinical problem and also the natural history of pancreatic exocrine insufficiency, because which is significantly different from acute chronic pancreatitis, where it was irreversible damage, and the acute pancreatitis, the natural history changes over time. So after addressing these two issues, then I will discuss about the main task, that is test and treat or treat all. So coming to the prevalence of pancreatic exocrine insufficiency, I would like to highlight two important recent meta-analyses published. The first one is in 2018 from Dutch pancreatitis groups, where 32 studies included in 1415 patients, and the prevalence of pancreatic exocrine insufficiency is around 27%. But the main limitation of this meta-analysis is they evaluated only the follow-up data of the patients after the index admission of acute pancreatitis. So we need more important to understand additional factors. For example, in this subsequent meta-analysis in 2019, they have divided the studies published on evaluating the index admission and also during the follow-up. So 10 studies addressed the index admission, where we can see the PE was almost in 2/3 of the patients. In the follow-up data, it is seen in about 1/3 of the patients. But the problem with these two meta-analyses, there is a high statistical heterogeneity and variable methods are used to test the diagnosis, and majority of them are retrospective studies and short-term follow-ups. So we need to have a long-term follow-up, a prospective study, probably multi-center study, and this paper addressed, Dr. Vikesh Singh is author in this study, where 112 participants were studied. Fecal elastase 1 was the test used to diagnose PEI, and you can see at the baseline the prevalence of PE is around 43%, and the fecal elastase test was performed regularly at 3 months and 12 months, and you can see at 12 months there is a prevalence of almost around 34%, which is almost in comparison to the previous meta-analysis. So after knowing the prevalence, it's important to understand the mechanism of PE. For this, we need to understand what are the variable risk factors and also the pathophysiology. So most of the studies or the meta-analysis or the data highlighted that 3 important risk factors. Among the etiology, alcohol, the severe acute pancreatitis has higher risk than mild pancreatitis, and pancreatic necrosis is also a predicting factor for the development of PE. In addition to that, the previous study also highlighted 2 important factors. That is, the first one is idiopathic etiology, which was not addressed before, but this paper highlighted that idiopathic etiology, because of probably the genetic predisposition or a future recurrent attacks or the natural history causing the predisposition, and also the presence of pre-existing diabetes, which indicates that there is an additional endocrine dysfunction also gives a risk factor for the development of PE. So pathophysiology includes acinar cell injury, and also in acute pancreatitis there will be pancreatic necrosis, pancreatic ductal disruption or disconnection, and intervention either because of endoscopic necrosectomy or the surgical necrosectomy increases the risk. And also in patients with pancreatic ductal disruption, there would be a disconnected pancreatic duct and subsequent atrophy. So all these factors predispose to the development of PEA. So coming to the natural history, in the meta-analysis what I highlighted before, of the 10 studies which studied the index admission, 8 evaluated both at the index and also follow-up period, where we can see the difference of from 71 to 33% during the follow-up. And also you can see the prevalence rate is high at the baseline, which slowly declines at 3 months and 12 months, and some patients newly develop PEE during the follow-up time. So what happens after 1 year? And this meta-analysis has shown that there will be a significant drop, almost to 1/3 at 1 year, and at 5 years, the prevalence is around 15 to 20%. Of that, the PEE becomes static because of the loss of pancreatic parenchyma or the atrophy or the recurrent attacks. And what happens if you don't treat PA? Because we know that definitely we should treat once it's there, because it can cause malnutrition, weight loss, and decreases the quality of life. So for this, we need to have an important study that can assess the efficacy of PERT in this group of patients. Majority of the studies are retrospective studies, and this is a prospective RCT, but the sample size is small, and this study has shown that there is definitely a positive impact by giving PERT, but that did not reach the statistical significance due to certain limitations in the analysis. So at this point, we understood 4 important clinical conclusions. 1, PEE is existent in acute pancreatitis with the prevalence of around 2/3 at index, and which subsequently falls to 1/3 in the follow-up period. And the natural history of PE in acute pancreatitis varies, and PE definitely decreases the quality of life, and we need to treat this. So once we understood, now we are going to discuss what is the next option or question that we have. Should we test and treat, or should we treat all, or which one is better? First, I would like to discuss about the test and treat approach. So the name itself looks ideal, because you diagnose, you document, you confirm that there is a PE, and then you are going to treat. So looks ideal. And also it is recommended by the guidelines, not for this indication, but at least for the chronic pancreatitis. And another important thing is, if you just rely on the symptoms for PE, sometimes it can be misleading. For example, if you take acute pancreatitis, if they have a watery diarrhea or acute diarrhea, especially after starting NGF feeds, the test or the diagnosis completely may not be reliable, and weight loss is also multifactorial or because of various factors. So we cannot rely completely on symptoms. And another important entity I would like to emphasize here is, not only a severe pancreatitis, but also mild pancreatitis also increases the risk of PE. For example, if you see at index point, there is, in about half of the patients of mild acute pancreatitis, there is exocrine insufficiency, and during the follow-up also, the prevalence drops to 20%. That means still a significant proportion of patients with so-called mild acute pancreatitis also would be having a pancreatic exocrine insufficiency. So if we rely on only the high-risk category, we lose the opportunity. So it's important to test for the presence of PE. And also the clinical course of PE changes naturally over a period of time because of pancreatic regeneration. So if we have a baseline value, then we can monitor the response during the follow-up of these patients. But the limitations or negative aspects of this strategy, it's a costly affair, many patients cannot afford, and then the compliance becomes an issue. And another important complicated factor for this is, we don't exactly know how long we should continue because of indefinite duration of the treatment. So these are the limitations of this strategy. So how to test, or what is the, I'm sorry for this slide. So there are various tests to evaluate the pancreatic function test. We have direct test and indirect test. And recently the most popular one is fecal elastase 1, because it's simple, easy, readily available, and diagnosed to a reasonable extent in many of these patients. Coming to the second strategy, that is treat all approach. So we know that there are certain high-risk groups, either by alcohol or severe pancreatitis or pancreatic necrosis, especially the more than 50% of the necrosis. And also we also know additional risk factors like idiopathic etiology or pre-existing diabetes. So when we know that there are high-risk patients and definitely they might be having a PE, we can directly start treatment in these approach. Why not? Why to waste unnecessarily for the test strategy? So another limitation of the diagnostic test is they are not readily available everywhere, and if you rely completely on fecal elastase, it's a very good sensitive and specific test for the severe pancreatic exocrine insufficiency, but not for the milder forms. And also it can be confounded by the dilution of the stool liquid, though it has a negative predictive value is high. And in the studies also, when they analyzed fecal elastase, the prevalence was low because of the so many confounding factors. And by using this test, maybe we underdiagnose, and also there may be some subclinical maldization. So definitely both the strategies have some advantages and some disadvantage, but this brings to our notice that there are definitely some unmet needs which we need to address in the future studies. The first one is we need to have a accurate or widely available method for the diagnosis of PE. And we need to have a large RCTs to evaluate the efficacy of PERT in these patients. And also we need to have a strategy how to de-escalate PE once we start the pancreatic enzymes. So these are the ongoing few studies that have come across while reviewing the literature. Probably in the next future, they may be going to address all these issues. So coming to the final question, after discussing all these, which strategy is to be adapted or which one is better? So there should be a logical or a balanced approach, I would say. Any patients with acute pancreatitis, we should try to test at least before the discharge for PE by fecal elastase 1. If the test is available, do the test. If PE is present, give and start the pancreatic enzymes. If the test PE is absent, there is no need for pancreatic enzyme replacement. When the test is not available or can't be done, then we need to identify the high-risk group factors and we start treatment with the pancreatic enzymes. But in both the scenarios, it's very important to understand or have idea about the high-risk groups. For example, in first strategy, by just relying on fecal elastase 1, we may miss few patients if the test is negative because of the limitations of the test. Whereas in this approach, you can see the risk of PE is also high in mild pancreatitis group, non-high risk group. So we need to have a high index of suspicion for the symptoms, and accordingly we should monitor, follow up and treat. With this, I conclude my talk. Thank you.